This is, guys, the most superior part of the anterior compartments of the lower extremity. And you know what is important? This is the region which is located not like normally frontal structure, but this is the region which is located in horizontal direction. And it is mainly covered by inguinal ligament, which forms not only superior but anterior border of this region. That's like, then you will look just to your patient from in front. You will not identify the structures which belong to the subinguinal region. Come on, but why so late? Come. Try to come in the time, okay? What is your name? I don't listen.
Abba.
Next time you will have absent. Abba. I must not make any marks in my register. Let's have a look to me, please. This is the pelvis. Sometimes you think that that is the normal position of the pelvis, but that is not normal position. This is normal position. It is the ventropedal structure. That's why it is turned to in front. And in that position, I will put now my pen in the place of the inguinal ligament. I see some abnormality. First of all, you come late, and God knows why you are standing up in front of my door. So ask my permission. Say, sir, knock the door. Say, sir, can I come? But you are standing at the abnormal. It's so funny. So funny person, go from my room quickly. So ununderstandable. He interrupt me and he is laugh and smile that he, like Santa Claus, he made for me the gift. Once again, look to me, please. This is the normal position of your pelvis. And if in that position I will put now inguinal ligament in its place, it will close and cover the space which you see between ligament and between bones, this narrow space. Let's say the picture which you see now, and which is completely in frontal plane, show all these compartments, that is not the physiological position. Pelvis is turned to upwards. And you look from the lateral side. So guys, that is very important, because if you don't identify position of the picture, in the future you cannot find anything during the surgery. You must understand the real position of the structures. Let's say, as usually, we start from borders of the region. Again, I put my pen in the place of the inguinal ligament, something like this. And let's discuss now what is the borders of this narrow space. From up and from in front, you can see inguinal ligament. From back and from below, you can see pelvic bones. By the way, two pelvic bones you can recognize here. Upper one belongs to the iliac bone, not ischiaticus. It is iliac. That is ischiaticus. Lower one belongs to the pubic bone. And this protrusion, it is junction place between pubic and iliac. Junction is called synastos. Synastos, you know, it is connection between two bones by bony tissue. Except synastos, we have synchondros and syndesmos. Syndesmos, it is connection by ligaments. For example, sacrospinal, sacroiliac. Synchondros by the cartilage, for example, symphysis. Remember it, please. This is important. And this synastos we call eminentia ilia pectinea. Because pectineus, it is same pubic, in Greek, ilia, it is iliac bone. That's why once again, superiorly, anteriorly, you have inguinal ligament. Posteriorly, inferiorly, you have pubic bones, which is covered by proper fascia. Medial side, here you can see the medial side. That is ligament. which is joined between inguinal ligament and pubic bone. We call it lacunar ligament. Or by author, we call it Gimbernat's ligament. Once again, medial side, it is the ligament which is called lacunar or Gimbernat. Laterally, we have just junction between inguinal ligament and anterior superior iliac spine. Anterior superior iliac spine, it is one from 4 spines, which has iliac bone. Anterior superior, anterior inferior. Posterior superior, posterior inferior. So we now speak about anterior superior iliac spine. What is your name? Anna, tell me please. Then I speak inguinal ligament, about inguinal ligament. What does it mean? Which anatomical structure is it? I am sure that during your anatomy you studied. So let's remember, what is the inguinal ligament?
It is a duplication of external oblique.
Aponeurosis. Let's say once again, guys, look, I hope, but I spoke about it. I don't understand, but you say that I didn't listen. I start and immediately stop. Okay. I start to sleep. But why, friends? Generally, I don't understand. Why in your groups or misunderstanding is happening? Because after the gluteal region, we study subinguinal because it is upper to the femoral region. Why we goes firstly into the femoral region, then from femoral regions come back to the subinguinal region. This is the logic of this. I'm confused, really, I don't understand. But one more question. Lecture we have every week or once during 2 weeks?
Once during 2 weeks.
In the previous week, am I have lecture with you?
No, sir.
No. So your lecture, it is in this week.
Yes, sir.
Maybe this is confuse us. I don't know. I don't understand really what is happening. Okay, anyhow, let's say duplication of the inguinal ligament we call external oblique abdominal muscle we call inguinal ligament. As you can see, between anterior superior iliac spine, my right hand, and between pubic bone, my left hand. Let's say this inguinal ligament, as I told you, it is anterior superior region. We understand the borders. Now, question number 2, make subdivision of this region. Now, look in the picture, please. If you look attentively look to this picture, you will see some very narrow aponeurotic structure, which is anteriorly start from inguinal ligament and posteriorly fused with the pubic bone. More exactly, it's not pubic bone, but it is protrusion, which is connected pubic and iliac bone, which is called eminentia iliopectinea. This narrow septa, which is connected two borders to each other, we call arcus iliopectineus. This is fascia aponeurotical structure. And it is originated from 2 sources. First of all, inguinal ligament, and second source from downwards. It is pelvic fascia, which is from pelvis descending up to these bones. I want to remind you that pelvic fascia, in the future we will study it, yeah? But from anatomy you know it, has double layers. One we call parietal layer, it is covered the walls. Second we call visceral layer, it covered the organs. By the way, above the pelvis, in abdomen, this function has serous membrane, which is called peritoneum. Peritoneum also has parietal layer, which is covered the walls, and visceral layer, which is covered organs. Inside of the pelvis, we don't have serous membrane, we have fascia. And that fascia split it into parietal and visceral. Immediately in the wall, we will have parietal layer, which we call fascia iliaca, because it covers mainly iliac bone. That's why we call it iliac fascia. That's why look. Now imagine that between my roof and floor, there are one wall. From roof, it is originated by inguinal ligament. From floor, it is originated by iliac fascia, and they fuse to each other. 1 minute attention to me. These arcus iliopectineus, as you can see, all these narrow space split it into two apertures or two compartments. Lateral, which we call muscular, and medial, which we call vascular. In the Latin, we say lacuna musculorum and lacuna vasorum. But minute attention. This fascia, which is located downwards and called iliaca, continues in two sides. One side goes immediately to the iliac bone, why it's called iliac fascia. Another covers the pubic bone, immediately superior branch. And it is renamed here and called fascia pectinea or ligamentum pectineum. Everything is simple, guys. Name connected with structure. If it is covered iliac, we call it iliac. If it's covered pectineal, we call it pectineal. No any puzzle. Is it understandable for you? But it's also not enough. Also, it is give the capsule for the muscle, which is located inside of muscular aperture, and which is called musculus iliopsoas. This muscle, guys, started from your lumbar region, descended into your subinguinal region, but it's not all. Then we draw it together in my lecture in the upper cross-section of the femoral region. As you remember, it forms the floor for the femoral triangle. And I spoke about it in my lecture. As you remember, femoral triangle forms floor means by two muscles. These muscles located obliquely to each other, and they forms iliopectineal depression. One muscle iliopsoas, second is pectineal. There's an iliopsoas, that is the muscle which is belong to three regions of human body. First is abdomen, because lumbar region it is part of abdomen. Second is subinguinal region, and third one it is femoral region. Remember about it, please. Inside of this medial space, except the muscle, there are two nerves. By the way, painter draw only one, which is deep. And you can see it is located between septa and between the muscle, and we call it nervus femoralis. Nervus femoralis, it is the biggest nerve from lumbar plexus, and second biggest nerve of the lower extremity. First biggest nerve, it is not from lumbar but from sacral and called nervus ischiaticus. That's why this is second biggest nerve of the lower extremity. It's very important, but it's very short. It is big because it is wide, but it is short. It is reached up to the upper third of the thigh region, and as you remember in femoral triangle, it is split into the terminal branches. Partly muscular, partly skin. And you remember the longest branch of it we call nervus saphenus. As you draw in your lecture, in middle and lower third, this is nerve which is inside of main neurovascular bundle, not femoralis, but its branch saphenus. And as you remember, nervus saphenus, starting from lower third of thigh region, become to subcutaneous fatty tissue and start to innervate the skin. And then you will find it up to your foot region, and it will pass with greatest superficial vein of lower extremity, which is called vena saphena magna. By the way, both will be finished in the level of the anterior margin of medial epicondyle and vein and nerve, and they supply the medial surface of the foot region. Is it understandable for you? So remember, please, nerve, which you see now in the picture, between arcus iliopectineus and musculus iliopsoas, it is nervus femoralis. Here is the second nerve. Unfortunately, it's not drawn, but it should be vice versa in the lateral side, between the iliac fascia, which is covered iliac bone, and the same musculus iliopsoas. And it should be called nervus cutaneus femoralis lateralis. As you remember in previous our lesson, we draw it in cross section just in the lateral side of the fatty tissue. And we say that it's innervated skin in the lateral surface of your thigh. And also it is from lumbar plexus. By the way, guys, I think you understand from my previous class that medial surface of thigh is much more better innervated than any other surface. Do you remember 3 nerves in upper third, 1 special in middle third, 1? For all other surfaces, there are only single nerves which make innervation. Practical meaning is simple. Unfortunately, wounds in the medial surface, traumas, I don't know, the bites, I don't know, anything which is make irritation of the some sensory nerves will be much more painful. Because we have more receptors in the medial surface comparable with any other surface. More of these, guys, I want to remind you that in the medial surface of the thigh region, skin is much more loose and it doesn't firmly connect it with deep layers. That's why in the medial surface, wounds will be tear, falciform, and very big. We call it even the flower-shaped wounds. Why? Because even not so big trauma can widely disconnect this loose skin from deeper located structures. You cannot imagine the same for the lateral or for the posterior compartments. Why? Because skin by the superficial fascia, septus of superficial fascia, fused with deeper located structures. And it's not so simple to disconnect its skin from deeper located structures. But in medial surface, it's very simple. Is it understandable for you? Remember about it, and let's come now immediately into the medial side of our space. As you can see, medial side doesn't have muscles, but it has vessels and it has loose connective tissue. Let's start from the vessels. These vessels you know very well. In my previous class, we draw these vessels in femoral region. But this is the vessels which is originated inside of the pelvis. This is the vessels which is continuation of external iliac vessels. And the border point between external iliac and femoral vessels, it is immediately midpoint of inguinal ligament. Above it, we call it external iliac. Below it, we call it femoral. They say this is region which is border, we can say, between above external iliac and below femoral. But starting from this region, we rename the vessels and we call them femoral vessels. Femoral vessels, guys, this is magistral vessels for the lower extremity. Lower extremity doesn't have any other big sources of supplement except 2 in the back. Gluteus superior, gluteus inferior. But you know what is the specificity of gluteal vessels? It doesn't descend it to down. They supply only the gluteal region. But single artery which will reach and which will give the branches up to your toes, it will be femoral artery. No any others. Is it understandable for you? Up to fingers it will go. If it's so, you understand, so problems we will have in case of the trauma of these vessels, especially in subinguinal region. Why I say especially here? Because no place for tourniquet applied. Sorry if it is happened in the lower parts of the extremity, in the region with single bone, which is thigh region, you can apply the tourniquet, make the cross pressure, and to make the temporal arrest of the bleeding before hospitalization. Otherwise, guys, look to my finger. This is so thick structure. And you understand that we will need very short time to be died by the bleeding from this artery, 4 or 5 minutes normal, not more. This is like tube. Say then this artery damage, you have critically short time to make some treatment, to make some temporal arrest of the bleeding. And again, I say you that is technically not simple. After then we will study operative surgery. Of course, I will tell you what is possible to do. But generally, remember, no so much chances, especially if there are complete cutting of this artery. If there are just apertures, that is second problem. But if there are complete cutting of the arteries, situation is not good. Absolutely. By the way, in the thigh region, I told you that we can project this artery also to make access to this artery. You remember, it is completely located inside of medial interfacial space. By the way, you remember that in upper third, we call it triangle, in mid third, we call it groove, and in lower third, we call it channel. Adductor's channel, or Hunter's channel, or femoropopliteal channel. And projection, guys, it is imaginary line from midpoint of your inguinal ligament to the anterior margin of the medial malleolus. But extremity should be flexed in two joints and will be externally rotated. Only in that position, by the line which I mentioned, you can project it this artery. By the way, you can see that inside of the subinguinal space, vein has more medial position. Same medial position will be kept inside of femoral triangle. Artery located laterally. And inside of this space, for both vessels, we have facial sheath, which is originated from arcus iliopectineus, come to the vessels and completely cover them. And what is important, and in subinguinal space and in femoral triangle, vessels will be split from nerve. In subinguinal space by arcus iliopectineus, in femoral triangle by Gauger septa, which I said you last time, which is remnant of this arcus. As I remember, please, vessels and nerve, it's not in same one common space. They split it by proper fascia from each other. Look attentively in the space. You see that medially to the vessels, we have some free, ring-sized, or ring-formed, loose connective tissue. And that loose connective tissue we describe like deep ring of femoral channel. Remember this, guys, deep ring of femoral channel. Now, I will try to modulate this ring by my hands, by my fingers. Let's do the ring, and let's put it in proper position. If I will fix it in this position, will it show for you the deep ring of the femoral channel? Of course no, because that is not frontal, but that is horizontal stretch. So I must to put it not in the frontal, but in the horizontal. Can you give me one pen? Much more better put it in this angle. No, horizontally. You don't know what is horizontal. Horizontal, it is that. Now put it here. You see that I put my pen immediately, not our friend pen, immediately in front of this ring. What is modulated, this pen? Inguinal ligament. So my ring located behind the inguinal ligament in the horizontal plane. And that is deep ring of the femoral channel. Now our friend look in the picture and say, why in that case this ring is drawn in the frontal plane? I say you 100 times why, guys. You are not so clever and attentive. Because that is not the real position, but this is turned to above. And instead of the horizontal ring, which is normally located here, you see frontal structure. Again, you don't understand. If I will hold now my hand in that case, in normal position, it will be horizontal, but if I will turn it to you in such a way, it will become to the front. Do you understand it or not? Okay, now let's describe the walls of it. All the walls is visible in this picture. Now look to me. In front and above, inguinal ligament. Behind and below, pectineal, medially lacunar ligament, laterally the vein with its capsule. Everything more is simple, yeah. So every border is drawn in this picture: anterior, superior, posterior, inferior, medial, lateral. Okay, but channel cannot have just one ring. So minimum we should see 2 rings for the channel. And here is the second ring I draw and describe you in my previous lesson. Of course, it is thigh region, immediately roof of femoral triangle. If you remember, last time we drew the space A, yeah, which is medial interfacial space. And immediately in the roof of this space, we draw the aperture, which is hiatus saphenous. That's a roof of our triangle. Come to me, stand up here. Hold your hand like this and put it in front of this triangle. My hand is this triangle. His hand, it is the broad fissure, superficial layer of the proper fissure. And between his fingers, there are apertures. That's a roof of this triangle perforated, and the aperture which you see now we call hiatus saphenous. Thank you very much. You can sit down. Same ring is shown in this picture. Let's say behind of this broad fissure, even it's shown, it's visible, triangular shaped space. Laterally sartorius, medially vastus, adductor longus, and superiorly inguinal ligament. It is the borders of your femoral triangle: sartorius, inguinal ligament, adductor longus. And all these mentioned structures you can see covered by superficial layer of proper fissure, which you call broad fissure. And you can see that this broad fissure is evolutionally penetrated structure. And this penetration we call hiatus saphenous. And as I say you before, guys, from this penetration, biggest vein is passed, superficial vein, vena saphena magna, and by this aperture, it is drained into the femoral vein. Yesterday in my lecture we spoke about it. By the way, remnant of this proper fissure, as you can see, covered aperture. And it is penetrated. And we call it external cribriform fissure, fascia cribrosa externa. From these penetrated apertures, lymphatic vessels, vena saphena magna, enter inside of the triangle and drain partly into the lymphatic nodes, partly into the vein. Is it understandable for you? Now, we understand, guys, that our femoral channel has 2 rings. Again, let's modulate it by my fingers. Deep ring I apply in the horizontal plane. Now, how I must make the inferior ring? Of course, frontally. And I should touch these 2 rings to each other. Why? Because anterior border of our deep ring will be inguinal ligament, but same inguinal ligament will be superiorly to the superficial ring. So look, please, from my 2 rings, one deep, located in horizontal, second superficial, located in frontal plane. By the way, deep ring also will have upper coverage. If superficial ring covered by external cribriform fissure, deep ring, above the deep ring, we have the upper portion of pelvis and peritoneum. But peritoneum from downwards covered by 2 layers, yeah? It is transverse fissure and parietal layer of peritoneum. That's why this transverse fissure will cover deep ring from above. It is also penetrated. You know why? Because inside of the deep ring, normally, naturally, we have lymphatic nodes, which we call deep inguinal lymphatic nodes. And biggest one we call Rosenmüller-Piragov's lymphatic node, or signaling lymphatic node. If in this region there are inflammation or touchwood cancer, firstly this lymphatic node will be enlarged due to the metastasis. But normally lymphatic nodes should be drained, yeah, inside of the vessels, and these vessels pass through the transverse fissure, which is covered the aperture, and goes into abdominal lymphatic nodes. That's a transverse fissure penetrated, and it calls internal cribriform fissure. And so once again, superficial ring covered by external cribriform fissure, deep ring covered by internal. Little after you will see what the practical meaning. Now 1 minute attention to me. Again, let's modulate these two rings. One in horizontal plane, second in frontal plane. Do you see any communication between them? I know. This two ring doesn't have any channel normally, which is connected them to each other, because nothing didn't normally pass between these two rings. This is the case why we say that femoral channel, it is pathological structure. Normally, these two rings doesn't have any connection. Normally, femoral channel absent. Rings is present, but channel absent. Do you understand what I tell you or not? This is very important. Usually, guys, we make comparisons between two channels, inguinal and femoral. By the way, border between these two channels, it is inguinal ligament. Inguinal channel located above this ligament, femoral channel located below this ligament, as I said before. Inguinal channel, it is normally exist structure. You have it, I have it. Femoral, normally absent structure. We don't have it. By the way, in the second part of this semester, then we will start to speak about abdomen. Part of my lessons will be about inguinal channel, content, hernias, treatment of these hernias. That is very big part of this semester subject. But generally, look to me. Again, I put my hand above in the level of the inguinal ligament. So above my hand, I now modulated, look everybody to me, I modulated the inguinal channel. Between my two hands, there are this space, which is called inguinal channel. How this space is formed? My left hand, it is free margin of two muscles, internal oblique and transverse. You can see that these two muscles doesn't fuse with the lower part of inguinal ligament. They fuse only with upper part. And space is formed between these two structures. This space is called inguinal space. This is space between the roof and between floor of inguinal channel. That's a superior border of the channel. It is my left hand, free margin of internal oblique and transverse muscles. Inferior border of the channel, it is inguinal ligament. Anteriorly, I will have external oblique aponeurosis, which will form inguinal ligament downwards. Posteriorly, I will have transverse fissure. This is the walls of inguinal channel. Just the refreshing of your knowledge, because you study it from anatomy. Once again, remember please, inguinal channel normally exists structure. By the way, like the femoral channel also, inguinal also has two rings, deep and superficial. I told you 4 walls. Now look, my room, it is inguinal channel. Above me, my roof, it is free margin of two muscles. My floor, it is inguinal ligament. In front of me, I have external aponeurosis. Behind of me, I have transverse fissure. What is deep ring of this channel? It is aperture on the transverse fissure. What is superficial ring of my channel? It is aperture on the aponeurosis of external oblique. As you remember, external oblique aponeurosis of inguinal ligament near the pubic bone split it into 2 legs. Medial fuse with the symphysis, lateral fuse with the pubic tuberculopubical. And you see triangular shape aperture is open. This is superficial ring. By this aperture for the males, channel communicated with scrotum. And spermatic cord by the channel, I'm very sorry, through this aperture, descended into the scrotum and fused with the testis. For the females, it just bluntly finished in the level of the pubic bones, and round ligament fused with them by this aperture. That's all. But now we speak not about inguinal But we speak about femoral channel. Now we should understand how pathologically this channel is originated. Again, come to me with your pen. There is my pen. I use my pen. But here, that is not so important. No, stand up here. Now, our friend, it is some intra-abdominal structures, for example, small intestine. And now he will try to form the hernia. Hernia, which is located not above inguinal ligament, but below inguinal ligament. Because if he will make protrusion above the inguinal ligament, he will be called inguinal hernia. But he will make protrusion below inguinal ligament. That's why he will call femoral hernia. Now please, inserted your pen into my deep ring. Thank you very much. Nothing more. Just no tip insert in the deep ring. Nothing more. Now look here, please. Imagine that inside of peritoneal cavity there are very high pressure, and my deep ring, God knows why, stand very weak. That's I remember, please put the chair and sit down to not read so long. Because time to time I will use your help. What the problem here, guys? Only weak place is not enough to form the hernia. Otherwise, everybody will have it. I told you last time, if I don't mistake, or I tell you now, that hernia originated in the region of the weak places of the human body. Minute attention to me. First of all, listen, and you will write. What does it mean, weak place? This is some part of our regions, body, which lacks some layers, comparable with neighboring structures. For example, look in this picture and tell me, please, why this white aperture, which is deep ring, weaker than surrounded regions? No vessels, no ligaments, no muscles, nothing. If you look to medial compartment, you will see vessels, which is strong. If you will look to, lateral. If you will look medial, you will see Gimbernet ligament. If you will look anteriorly, you will see inguinal ligament. If you will look backside, you will see properly bone. That's comparable with neighboring four structures, anterior, posterior, medial, and lateral. Here we have weakness. Now look to the inguinal channel. Why inguinal channel it is weak? Because in this channel place, these two free muscles, as I say, doesn't reach the level of the inguinal ligament. That's why inside of the channel, these two muscles is absent. Two very powerful muscles absent in this channel. It makes this channel the weakest place of human body. So the most usual place of the hernias, it is inguinal channel. Why your umbilicus is weak? Because no muscles. This is white line of the abdomen, and very wide white line. The more bigger is weak place, the more chance of formation of the hernia. Let's say, look, please, I give for you now definition of the weak place. Weak place, it is part of the human body which doesn't contain some layer comparable with neighboring structures. Do you understand me or not? Repeat it, please. What is the weak place? What is the weak place?
Comparatively to the other
Not just other, neighboring.
neighboring layers.
What is absent comparable with the neighboring region?
The layers.
Some layers, yeah. Some layers absent. Now look, guys, everybody, all human population have these weak places. But touch wood, it doesn't mean that all human population have the hernia. Now, what else we need for formation of the hernia, if not only weak place? Who will tell me? I will put 10 immediately, because that is just logical. No, dear, if you will go today to the gym and will make, for example, some physical exercises, your intra-abdominal pressure will be increased. But I'm sure that it will not give for you immediately formation of the hernia. If you will take now something heavy, your intra-abdominal pressure also. Sorry, if you will go to toilet and will have defecation, your intra-abdominal pressure also will be increased. But I don't see that you have protrusion due to it. That's why I don't agree with you. Now, what is necessary?
The organs are protruding into the space, pushing the.
Protrusion is happening, as you say, due to high pressure. So we have high pressure, we have weak please, but still we don't have hernia. Friend, do you like in your life to have comfortable conditions? You don't like comfort. Organs also. You know, for organs, comfortable condition, it is place with low pressure. Organs try to find the place with the low pressure. So if there are possibility for them to be inclinated in a region with low pressure, they try to do it. But God knows why we have weak place, we have high pressure, but these organs doesn't form the hernia. So what else is necessary to do it? It means we don't mention etiological cause of the disease. We mention only some risk factors. Do you know what is etiological cause and what is the risk factor? Etiological cause of the disease, this is the cause which is give formation of the problem. Risk factors make more possible formation of this problem. But by itself, risk factor cannot give formation of disease. For example, now inside of our environment, there are 100 million viruses. This is etiological causes for formation of infection. But only this virus is not enough. I must have risk factor, for example, low immunity system. Let's say for my influenza, low immunity system will be risk factor, but virus will be etiological cause. Let's say weak place and high pressure, it is not etiological cause. It is risk factor which make possible formation of disease, but it is not the cause of it. Now what will be the cause? Friends, you just don't want to be friendly with your brain, with your gray matter. Cause of it will be weakness. He say one example, I can say another, of weak place. If God knows why this weak place become to more weak, it can be happen after surgery. It can be happen after trauma. It can be happen because of vascular diseases. It can be happen because of the problems of innervation. It can be happen due to the metabolical disorders. It can be happen due to the hormonal disorders. For example, smoking is your behavior or not? Who is smoke from this group? You. Tell me please, if you will compare your chance and his chance of formation of the hernia, who will have more? Why? 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 Because of the vascularization problem there. Nicotine make the vasospasm. Vessels of your weak places will not properly supply these regions. And we can have weakness of weak place. That's why I look down here. Weakness of the weak place, it is etiological cause of formation of hernia. High pressure will be a risk factor together with weak place. Now there are weakness. He was smoking. He has the weakness. Today he will go to the gym, takes a touch wood of course, take something heavy, and we can have protrusion easily. That's why remember please, only weak place is not enough for formation of protrusion. We should have weakness of the weak place. And we should have some risk factors. Now look to me. What is hernia? Definition. Hernia, it is protrusion of internal structures through the natural or artificial weak places, which is covered, I mean protrusion, by non-damaged parietal layer of peritoneum. So once again, imagine that I am organ, for example intestine. You, my two dear friends, it is part of my wall, for example abdominal. But you can see my two friends doesn't touch to each other. Between them there are distance. This distance will be weak place. Yes or no? Because here we have strong protection, here also. But between them, no. If I will insert it now, my hand, between these two peoples, if my hand will be covered by non-damaged parietal layer of peritoneum, this pathological condition will be called hernia. Let's say look to me and remember forever. Hernia should have 3 structural units. Unit number 1, minute attention to me. Friends, let's have conversation. Because listening, it is active position. Writing, it is passive position. Then you write, you are not involved in the conversation. Much more better if you listen. Now look, again I say, hernia, it is protrusion of internal organ. My hand, it is internal organ. It is covered by sac, non-damaged parietal peritoneum. And it is come to outside through the weak space. Let's say hernia should have 3 elements, 3 units. Listen to me. Weak place we call ring of the hernia. Parietal peritoneum we call sac of the hernia. My hand we call content of hernia. So listen and remember forever, once again. Then we say hernia, we imagine ring, we imagine sac, and we imagine content. Now our friend, which is inserted pen in my ring, modulated, sit down please, this content, which is covered by sac. I modulated the ring. Together my ring, his sac, and his content called hernia. By the way, in the time of your investigation, you will strongly find, you can strongly find, only 2 compartments from this tree. Sac and ring, because content can come and can go back. Such kind of hernias we call reducible. Then pressure increased, content come to outside. Then pressure decreased, content go to inside. Reducible. But except the reducible, there are 2 another forms, strangulated hernia and non-reducible. What does it mean non-reducible? That is sac, that is content. They fused to each other. What does it mean strangulated hernia? This is content, this is ring. Ring is press content. Of course, in both these cases, content cannot be reduced. And that is 2 cases which will give the pain. Because reducible hernia is not painful. Why it should be pain? If I can simply come and go back. But if I will be pressed, my receptors will be irritated. But I will give the pain. Is it understandable for you guys? Remember forever, once again, hernia, it is protrusion of internal structures through the natural and artificial weak places. I told you what is natural place. He told you what is an artificial place. He said, after surgeries or after the traumas, we can have the scar. Scar, it is artificial weak place. Why? Because then I cut, for example, these 3 layers. Instead of these 3 layers, 1 connective tissue structure will be formed, which is called scar. Scar doesn't have elasticity. Then you press the scar, you usually split it into the fibers, and between the fibers anything can be passed. Normal tissues have high elasticity. They can be dilated and constricted. You press them, you dilate them, then you remove the pressure, they constricted them. Now imagine that you have 2 structures. One structure is elastic rubber, second one, for example, plastic bag. What is happened when you push the plastic bag? Protrusion, which cannot be reduced. What is happened when you press the rubber structure? Elastic protrusion, which after constricted. So remember, please, guys, remember forever. Sac of the hernia, which is formed by parietal layer of peritoneum, it's not elastic. Then it is protrused, it cannot be reduced. Content of hernia can reduce or not, but sac no. This is very important to understand, friends. And again, we understand now together what does it mean the natural weak place and what does it mean artificial. Now we have natural weak places. It is deep weave of the femoral channel. Again, my dear friend, to not be so hard for you, come sit down from this side. And again, try to insert your pen inside of my first ring. Now 1 minute, wait, fixing this position. His hand, as I say, it is internal organs, which is covered by parietal layer of peritoneum. He makes some pressure into my superficial deep ring. But you know what is the problem, guys? This pressure cannot dislocate it anyhow deep ring. Why? Because partly it's formed by the bones. Posterior wall of my deep ring, it is bony structures, fascia pectinea, which is covered the bone. But he can try now insert this ring, this pen into spirit, and to push the superficial ring from deep to outside. Because superficial ring, it is completely movable structure because it forms by soft tissues only. It is defect of the broad fissure. Now, what will be happen then these two rings will be start to disconnected to each other. Connection between them will be deleted, and we will have formation of the artificial channel, which is connecting two rings to each other. Now look please, then I disconnected two rings to each other. Upwards, I have deletion of superficial layer of proper fissure. Why? Because cornu superior, it is superior margin of the superficial ring. It forms by broad fissure, superficial layer of proper fissure. Posteriorly, I will have the deletion of fascia pectinea, yeah, because posterior margin, it is past a deep layer of proper fissure. And finally, laterally, I will have femoral vein inside of its capsule. Thank you very much. You can sit it in your place. This is showing me that in cross section, femoral channel will have not 4, but will have 3 walls, and it will have triangular shape form. Anteriorly, we will have superficial layer of proper fissure. Posteriorly, we will have deep layer. Medially will be the gibberellin ligament, which is joint temperature. And my shoulder, right shoulder, will be femoral vein. Only in time of herniation, we will have formation of this triangular shape, artificial, abnormal channel, which is called the femoral channel. We must mention a little bit epidemiology of this problem. And we should say that this is mainly, more than in 90%, females problem. And we must mention that mainly old females, after 50, 55, more of these females with more than 3 deliveries. I don't see just pregnancies, because maybe it stopped pregnancy. Deliveries having the anomalous. But tell me please, why especially females? And why females with the pregnancies and deliveries? Your answer. Friend, you know what the problem? I don't know the Braille alphabet. Braille alphabet use the people who cannot speak. I can only understand your language. As I speak loudly.
Because of the broad space.
Why? First of all, which space you mean, and why it is broad?
In the femoral space.
Friend, if you want to sleep, go wash your face. No, I know that you won't. I know, because I know that my subject is not interesting for you, friend. Can you tell me what I asked her? Just repeat it, my question. Stand up, please. What is my question to your friend? Speak loudly, please. Which hernia? Which hernia? Which hernia, friend? That is stupid to say only women have all hernias. That's why there are a lot of hernias which is predominantly male problems. About which hernia, I ask her immediately now. So I prove you that you are asleep here. I say why femoral hernias, it is predominantly woman's problem. That's why, friend, it's very easy to say, doctor, you are wrong. That is not so. But it is very hard to prove that doctor who is 49-year-old and who is 25 years working in the medical universities have so small experience that don't recognize who is sleeping in the class and who is listening. Now you can sit down. Once again, we speak about the femoral hernias, and we try to understand why incidence of these hernias much more usual for females and very seldom for the males. Please.
Because of the broad space in the femur.
Which broad space? Again, I tell you, which space? For example, orbit, mouth, ears, which space? Subinguinal space generally bigger? Sorry? My dear friend, why you mix everything? She's absolutely right. Some space is bigger. This space we call weak place. I told you 2 minutes before, the bigger will be weak place, the more will be chance of formation of the hernia. I don't say that it is the etiological cause. It is risk factor. Etiological cause will be weakness of the weak place. Now, God knows why some weak place of females is bigger than for males. We must recognize now which big place, which weak place, I'm sorry, I mean, and you mean. Fantastical. Of course, deep ring of the femoral channel, because hernia originated immediately in the level of the deep ring. That's why God knows why females have bigger, normally, naturally. It doesn't mean that for females 100% we have this hernia. No. Normally, if you will compare your ring with my ring, you will see yours is bigger. But of course, it is not the single cause of formation of hernia. But we know that this ring, which is drawn in the picture, do you see it, or to show you? Do you see this white ring? This white ring naturally bigger for females than for males. Why? Why naturally this white ring of females is bigger than this white ring of males? Again, I tell you, we call it deep ring of femoral channel. Why it is bigger? He said why. 2 minutes before he said why. Because woman's pelvis generally wider than male's pelvis. What does it mean? Give me please. It means, look everybody to me. The more wider will be pelvis, look to me. Imagine that I stretch it. The more horizontal will be position of your inguinal ligament. The more horizontal will be position of inguinal ligament, the more will be this distance, which is located between inguinal and pectineal ligament. But sorry, this distance, it is anterior and posterior walls of the ring. You repeat what I tell you. Just repeat what I tell you. Why females' deep ring is bigger than males?
Because the pelvis gets wider.
And which distance is increased? Continue to sleep. Distance between inguinal ligament and between pubic bones or pectineal ligament. She is inguinal ligament. I am pubic bone, which is covered with fish. The more horizontal she will be located, the more will be increased the distance between she and between me. If this distance will be increased, ring which is located between us also will be increased. Now let's come to, okay, we understand why normally females have bigger ring, but sorry, normally females doesn't have any hernia. Now let's come to my second information, why I told you females after 50 and why I told you about deliveries. Please.
Because after the pubic bone is widened and
What? Maybe you?
after the delivery, this pubic bone will be widened and causes much.
No.
And
Like the Christian person, I will, Dawn will stand. Why? Are you serious? Once again, I ask the question for everybody. Why especially females after 50 and why with many deliveries? Many, it means 3 and more.
Pubic symphysis.
Ligaments get
Ligaments
weaker. The ligaments get
Ligaments what?
they get weaker.
And what will be happen? What will be happen with these ligaments?
They expand.
Ligaments will be dilated. We will have dilatation of the ligaments. They will lose elasticity. You know, guys, by the age, we don't stand more younger. That is big puzzle for you. Right to remember. Right, please. By the list. Fantastic. Why I say after 50? Because our tissues lose elasticity. And any next delivery will dilatate it inguinal ligament. She is again inguinal ligament. The more she will be dilated, the more will be distance between us. Now I mention for you etiological cause of formation of this hernia, the weakness of the weak place, which has happened due to some physiological or pathological processes. Is it understandable for you? That's why remember, once again I tell you, females after 50 with many pregnancies in anamnesis have much, it doesn't mean again that 100% of all mentioned females will have, but again they will have much more chance to achieve this. For example, they will take something heavy. For example, they will have constipation, which is increased depression. For example, they will have chronic cough, which is increased depression. For example, they will have more pregnancy after 50. It is not so usual, but possible. All these problems will give the chance for formation of the new protrusion. Is it understandable for you? That's why remember it, please. This is very important. Now look in this picture. What do you see immediately in this picture? Protrusion. You can see that intestine through this weak place. What is forget to draw our painter? Sac. Sac, guys. In the real case, all these we will have not like that, but we will have something like this. This is the ring. This is the green protrusion sac. And only inside of this green protrusion sac, we have some internal organ. For example, small intestine. And it will be called hernia. Ring, structure 1. Sac, structure 2. And hernia, structure 3. And you can see that usually, in majority of the cases, it is located immediately medially to the femoral vessels. Because here we have the ring. We can have variations. For example, from outside, how you can recognize it? Protrusion. You see the inguinal ligament, below inguinal ligament, you see protrusion. If the same protrusion will be above inguinal ligament, we will call it inguinal. Of course, thank you very much. Thank you very much. By the way, these inguinal hernias in the future you will study can have two main forms, indirect and direct. Indirect one will have protrusion from start of the channel to the finish of the channel. Because it is passed through the whole channel. That's how you call it indirect, because channel is oblique. And hernia, which is passed inside of it, called oblique or indirect. But there are second type of hernia, inguinal, which is called direct. In that case, protrusion will be immediately here, in the level of superficial ring of the channel. That is the hernia which doesn't pass through the channel, which immediately come to outside from superficial ring. We call it direct. But anyhow, it doesn't matter is it indirect or direct. Inguinal, it is above inguinal ligament. Now in this level, study it, because after in the future we will study inguinal hernias. So you look to your patient, you recognize the inguinal ligament. Now your problem is understand protrusion located above or protrusion located below. Then it is below, we call it femoral hernia. Then it is above, we call it inguinal. That's all. But there are one big problem, guys. Femoral hernia is usually small. This female also has small hernia, but you know why her protrusion is visible? She's very slim. She's very slim. Fat is bad development. Now, instead of that body, Imagine big body. In your opinion, this 1 centimeter protrusion will be visible or not?
No.
No. Unfortunately, no. You can ask me why usually femoral hernia is small but inguinal big. I told you why, guys. You are not attentive. I told you why. Who can tell me now why femoral hernia is usually small? I told you why. Because you just sleep in my class. Why it is small? Because I told you, guys. One fascia cover deep ring, second fascia cover superficial, and they will stop the movement of the hernia. This is two cribriform fascias. Sorry, in case of inguinal hernia, nothing doesn't cover the passage of the hernia. Let's say inguinal hernia will be up to the size of the football ball. Big, huge. And usually patient will see and recognize, even if it will be reducible hernia, not painful. Sorry, it is impossible to not see the huge structure. Doesn't mean that all people with inguinal hernia have the huge. But there are more chance for inguinal hernia to be big. And patient by himself, why I say him? Because mainly it is male's problem. Patient by himself will recognize it and will go to the hospital, will come to you and to say, doctor, what is it? I don't understand why I have this protrusion. Unfortunately, in case of femoral hernia, situation will be another. Usually patient in stage of reducible hernia without pain will not recognize the problem. Sorry, will I recognize my problem? Which point A, I'm visible, point B, I'm painful. Sorry, how? My fingers is not the ultrasound. I will not understand. And when I will come to you, dear my friend, when I will come to you? When? Unfortunately, it will be complication of the hernia, which can even kill us due to the necrosis of the hernial content. Don't forget about strangulation. Then content is pressed inside of the ring. And this pressure can make necrosis. Say sometimes you ask me, sir, what is better to have small or big hernia? It's better to not have hernia at all. But then the hernia is big, you see, you recognize it, and you don't lose the time. Then the hernia is small and painful. Sorry, how I will recognize it? How? And a little bit about the surgery of this problem. You can see in this picture generally that there are two access types. One below inguinal ligament, second above. We call it lower access and upper access. Of course, much more logical to make lower access because hernia located below inguinal ligament. You must to cut the skin, fatty tissue. You will see inguinal ligament, and immediately behind of it, you will find the inguinal, deep ring. Now, what does it mean, surgery of the hernia? It means point one. You should find the hernia. You should push content to inside. You should cut the sac near the neck of it, narrow place, which is inside of it, and remove it. Can I say that my surgery is finished? I must make plastical reconstruction, stage number 2, to prevent formation of new hernias, because we have weakness of the weak place. Yes or no? Then I make the low access. What is my logical method of plastical reconstruction? By the way, nowadays we have two methods. One we call by tension, second without tension. What is without tension? Mesh. Polypropylene mesh. We suture it in the weak place. It makes protection, prevent formation of the hernias. What does it mean, method with tension? You take one tissue, you connect it with another tissue, you tense it, and you make this weak place smaller. What I can suture now to each other, inguinal ligament and pectineal ligament. Not completely close because we have lymphatic, but to decrease the distance. Method is simple, easy, but method is not good. You know why? Tell me please, if I will descend it inguinal ligament, which kind of problems I will provoke? This is inguinal ligament, this is pectineal. I joined them to each other. What will be happening? say we don't completely close it, we just decrease the distance. You don't want to think, guys, gray matter for you is not so important. Again, look to me. This is inguinal space. Two muscles, inguinal ligament. I descended this ligament. What is happening? What is happening? What is? I increase inguinal space. Instead of femoral hernias, in the future it will give the inguinal. Much more better from that point of view to make suprainguinal access. What does it mean? You come to the inguinal ligament, inguinal canal now, opening, and take these two muscles and descend them to the pectineal ligament. Distance normally between them 2 centimeters, it is not hard. Instead, descending of inguinal ligament, you descending these three muscles. It is protected an inguinal space and femoral space because it makes the natural wall. Do you understand it or not? Friends, I love you very much, you know about it, but I not appreciated absolutely your passiveness in my class, especially when we speak about so important practical problems. We must have dialogue, but that is your. Here is mine.